نعم. A 40-year-old male presented with abdominal pain and distension.
Okay, plain film X-ray showing enlargement, bowel loop, extended from the pelvic, from the left side. And here هذه picture of large bowel obstruction.
هل هو هذا small bowel loop large bowel loop؟ طبعا الفيلم انت ما قلت انه هو هذا plain X-ray of abdomen correct or supine؟ مو صح ولا غير نقول abdomen correct or supine؟ هل هو هذا small bowel؟ هل هو large bowel؟
هذه large bowel obstruction وهنا hysterectomy.
نعم.
أو بعد ما عندي يعني قاعد باول بالركتم السمول باول ما قاعد أشوف، ويعني فهو يعني لايك يعني كاببين ساين و extended from the left iliac fossa to right upper quadrant.
بالعكس قاعد.
فهو ما نعم.
هذه اسمعيني.
نعم أستاذ. نعم أستاذ قاعد تسمعني؟ نعم أستاذ أسمعك.
Extend from the right, from the left to the right, or from the right to the left.
لا اي هو من الليفت، يعني قاعد اشوفه جاي من الليفت اللي بوسه ورايح توورد، يعني هو يعني شلون ال رايت ابر كوادرنت، وهو لايك كافي بين ساين، فهو يعني اكثر شيء هنا يعطيني بيكتشر اوف ذا سيجمويد فالفولس.
زين. هاي الفيلم هذا عرفت لو سوف انسى اول شيء اول مره اسمعيني سالي. عرفت لو سوف
نعم استاذ قاعد اسمعك يا اخي.
عرفت لو سوف ليش؟
يعني استاذ انا ما اقدر اقول عليه يعني الرت لو سوباي، ما قاعد اقدر اقول. اي لو كان يعني الرت صار بي اير فلويد ليفل.
زين.
اسمه الباول لانه هي يعني obstruction.
هذا سوباين. بس المفروض
او اكو بعد. نعم استاذ. وهو انا قاعد اشوف انه بس العفو استاذ والهارت صاير على الرايت سايد، اذا هذا الليبل صح فهو يعني ديكستروكارديا.
نعم. فانت بريد بين هذا سيجمويد فالفولس بريدجين.
اي هذا سيجمويد فالفولس.
نعم. تحتاج تسوين فد شيء ثاني بعد؟
يعني هو أنا بالنسبة لي يعني كتشخيص ممكن أشخص هذا سيجمويد فالفولس، بس إنه يعني ممكن نسوي له سي تي سكان حتى يعني تو اكسكلود يعني other cause، ممكن إنه ال cause of ال obstruction اللي صاير.
نعم. يعني تحتاجين تسوي سي تي تو اكسكلود other causes other than valvulus. زين. عندكم سي تي فرح؟
اي نعم دكتور.
يلا.
بس العفو دكتورة كبري لنا الصورة شوية.
ماشي.
أريد كورونا دكتورة. خلي وياه، خلي صورتين وكورونا وأكزيال. تقدرين؟
نعم.
دكتورة حكي لي الكورونا.
اي سؤال
دكتورة
شفتي
عندك
بالسي تي
منطقة ولا
معنا؟
ما مسوين؟
أي نعم أكو.
multi-slice CT scan showing severe distended ال descending colon transverse colon descending part يعني mostly more than 6 cm وهي أهسترا ماكو جاز باول بالركتم، ما شفت اكو جاز باول. السمول باول نورمال يعني ما بيها obstruction، معناها اليوسيكال فالف competent واكو انجي تيوب شفت. الأذر أورجان الكدنيات ما شفت بيهم شيء، البوث كدني والليفر والسبلين همات ما شفت بيه شيء. هم بالإضافة إنه يعني أنا ما شفت فد ماس هي يعني مثل obstruction أو هرنيا حتى يعني يعني to exclude other causes مع large bowel obstruction، فهو يعني هنا ممثل راح يكون السيجمويد فالفولاس.
نعم. زين. شنو الساين اللي ممكن نشوفيها بالسيجمويد
يعني
فالفولس
والساين مال perforation يعني قصدك أستاذ الفرق بيناتهم؟
اكو ساينز
أستاذ؟
بالسي تي، تسمعيني؟ صوتي واضح ولا
إي
لا؟
نعم أستاذ.
اي اكو
يعني قاعد
ساينز
يقطع شوية. أوكي أستاذ.
ساينز بالسي تي بالسيجمويد فالفولس، شنو هي؟ حددين اياها تعرفيها؟ يا موجوده هنا.
بس دكتورة حكي الكورونا حتى أشوف أكو تبيه موجودة. هي هنا الكافي بين ساين كلش واضحة اللي هي مالت
نعم.
السيجمويد،
زين.
والمفروض انه ماكو الاير بالركتم، همات انا ما شفت اير بالركتم. والبيك ساين اللي هي لازم ديك يعني لازم اكو كونتراست، هنا انا ما شفتها. وهو عادة السيجمويد كولون يبدي من الليفت اليك فصة ويروح باتجاه يعني الرايت ابر كوادرانت يعني على جهة الليفر. وزين أنا أريد الأمبارتد نيجاتيف، أنا ما عندي إير يعني إير أندر دايفرام، يعني معناها يعني ما عندي perforation.
شكرا سالي.
العفو أستاذ.
نور قاطع. نور موجودة؟ نور نور بابا.
نعم أستاذ.
صباح الخير نور.
صباح الخير سر.
نور, what are the signs of sigmoid volvulus and CT?
Sigmoid volvulus or direct dilated bowel loop, the originating from pelvis directed toward right upper quadrant. Oral pole sign which is represent swirled يعني swirled vessel around sigmoid mesentery. وأيضا bird beak sign which is tapered end of afferent and efferent lobe
نعم.
Of the bowel which is directed toward a obstructed point.
نعم.
وcoffee bean sign, this is seen in X-ray which is inverted U shape represented closed drop obstruction.
نعم.
يعني this is the sign seen in CT and X-ray.
Which one of these signs are present in this case?
I see swirl sign in mid of the abdomen.
No.
With inverted U-shaped sign.
تمام.
وأيضا هي يعني closed loop obstruction
نعم.
يعني
شنو
these
next?
three sign I see it in the CT.
شنو next step نور بلا زحمة عليك. شنو next step? What is the next step in this patient?
Next step since we don't have sign of perforation, although يعني I should check it also in see any lung window to see any air in the peritoneum or air under diaphragm. I should check the normal bowel wall enhancement. The bowel wall enhancement is normal and there is no air or pneumoperitoneum. So colonic decompression done in this case. After that, the patient prepared for surgical fixation.
تمام. شكرا نور. يلا فرح احكي لنا على الكيس ورفعته كذا عندك.
نعم دكتور. 40-year-old male presented with abdominal pain and distension. Supine abdominal X-ray show massive disproportionate gaseous dilatation of large bowel loop, giving the appearance of coffee bean sign. Features are highly suggestive of sigmoid volvulus. This is the CT scan report of our hospital. This is an intra-op picture of the patient. And this is the structural report which reveals massive disproportionate dilatation of the sigmoid colon, measuring about 13 cm in diameter with mild sigmoid wall thickening. Impression is of sigmoid volvulus with high-grade obstruction. Urgent surgical consultation for detorsion is recommended. So our subject today is sigmoid volvulus, presented by me, Farah Abdallah, second Iraqi board stage. First is our objectives is to define the sigmoid volvulus and its causes, detail the typical radiological finding on plain film and CT, and demonstrate how to distinguish it from other pathology, and lastly, recognize the imaging signs of complications. Sigmoid volvulus is a cause of large bowel obstruction when the sigmoid colon twists on its mesentery. It's considered the most common type of volvulus, more common in elderly and male. First described by von Rogtenski in 1836. Usually patient presented with a classical triad of abdominal pain, distension, and constipation. Etiology is multifactorial and controversial, but is generally attributed to redundancy of the sigmoid colon, dolichomesentery, which is described as mesentery that is wider than long, and also the narrowing of the base of the sigmoid mesentery. There are two subtypes of sigmoid volvulus. The first one is the mesenteroaxial, which is more common, where the sigmoid rotate around its mesenteric axis. Usually there are two transition points, and it's usually complete with a greater loop diameter and higher recurrence rate in comparison with the organoaxial, which is less common when the sigmoid volvulus rotate on its longitudinal axis. And there's a single transition point, usually incomplete with a smaller loop diameter and lower recurrence rate. This is two images, scout images of different patients with sigmoid volvulus showing the mesenteroaxial type and the organoaxial type. This CT scan show two transition points creating the X mark, the spot sign at the axial view, and the coronal view show the whirl sign in the sigmoid mesentery. This is a CT scan of organoaxial sigmoid volvulus of a 41-year-old female. The axial CT showed the transition point creating the peak sign, while the coronal CT showed the whirl sign of the sigmoid mesentery. Diagnosis. Plain film is diagnostic in about 50 to 90% when large dilated colonic loops and air fluid levels are seen. Colonic hysteria are lost, mainly located on the left side of the abdomen and extending toward the right hemidiaphragm. X-ray is considered as the first line. Signs that are seen by X-ray, first is the coffee bean sign, which represent dilated sigmoid colon with coffee bean-like shape. Second is the Freiman-Dahl sign, which represents a three-dense line representing the sigmoid walls, converging to the site of obstruction and usually associated with empty rectal gas. Liver overlap sign, when the sigmoid loop ascending to the right upper quadrant and projecting over the liver shadow. Northern exposure sign, which signify high specificity, the apex of the sigmoid volvulus is seen above the transverse colon, reliable on supine abdominal radiograph. These are X-rays of two different patients. And finally, the absent rectal gas. This X-ray of 62-year-old male show no gas in the rectum. Anemia, barium or water-soluble contrast, where Baird's peak sign is seen, bowel perforation and the risk of overlooking a bowel gangrene are potential hazard. Not used if the patient have peritonitis, bowel gangrene, or perforation. This is a gastrography in enema, confirm the diagnosis of sigmoid volvulus with a classic peaked appearance of contrast termination. CT scan is considered the gold standard in diagnosis. It's usually indicated in resolving inconclusive or atypical plain radiograph and in assessing bowel wall viability and ischemia, exclusion of underlying mechanical mimics and obstructive lesion, and finally in detection of intestinal perforation. CT protocol, optimal enhancement occur in late arterial phase, about 15 to 20 seconds after enhancement of abdominal aorta. A flow of 5 cc per second give a good enhancement. We should avoid a portal phase, and also we should not give oral contrast because enhancement of the bowel wall cannot be seen. CT signs of sigmoid volvulus include the whirlpool sign, when the bowel rotates around its mesentery leading toward whorls of the mesenteric vessels. The Baird's peak sign, gradual narrowing or tapering of the sigmoid colon up to the level of obstruction during contrast or barium insertion to the rectum or on CT. X mark the spot sign, which mean crossing loops of the bowel at the site of transition. Split wall sign, which means separation of the walls of a single loop of the sigmoid colon due to the invagination of mesenteric fat between them, signifies either a partial twist or an early stage in twisting or untwisting of previous complete twist. And finally, the steel pan sign, which means multiple separate segments of bowel on their rostral folds arranged in circular pattern. Signs of closed loop on CT, there are major and minor signs. Major include the odd configuration of bowel loops, mesenteric edema, and 2 points of obstruction, while minor include dilated small bowel, high-density bowel wall thickening, poor enhancement, and ascites and perforation. This CT scan shows the odd configuration of small bowel loops in patients with a closed loop obstruction. And this shows the mesenteric edema. Complications. First is the bowel ischemia and gangrene, which is seen as reduced or completely absent mucosal enhancement, or target sign or concentric wall thickening of closed loop, or pneumatosis intestinalis, which means gas inside the colonic wall. This CT scan shows no or minimal mural enhancement of the sigmoid with infiltration of the perisigmoid fat and mild intraperitoneal effusion, which indicates sigmoid ischemia. The second complication, perforation, which is detected by the presence of pneumoperitoneum or free fluid. This coronal CT image demonstrates the wear sign and cecal pneumatosis, while the axial CT demonstrates the extraluminal gas, which is indicative of perforation. Recurrence. Colonic volvulus in the left mid to upper abdomen involving the distal transverse colon and descending colon with gaseous colonic distension. The characteristic word pattern is also present in this CT. Differential diagnosis. First is large bowel obstruction from colorectal CA, which is the most common cause of colonic cancer, typically in the sigmoid. We see in this axial CT short stenosis rectosigmoid junction tumor causing a high-grade large bowel obstruction. Second differential is cecal volvulus, which account about 10% of all intestinal volvulus and usually occur in younger patients. This CT shows the terminal ileum and ascending colon, which can be traced to whirl around each other. The mesenteric vessels act as the axis of rotation. This is a point of differentiation between the sigmoid and cecal volvulus. When sigmoid volvulus usually arise from left side of the pelvis and extend toward the right upper quadrant, opposite to the cecal volvulus. The cecum usually gas-filled in sigmoid volvulus while it's empty in cecal volvulus. Small bowel usually empty or uninvolved while it is distended in cecal volvulus. Usually 3 lines or the Fry-Mandel sign, which previously was mentioned, seen in sigmoid volvulus, while it's 2 lines seen in cecal volvulus. The third differential is the colonic pseudo-obstruction, which is also known as Oglev syndrome, is a fatal condition leading to an acute colonic distension without an underlying mechanical obstruction. This patient have no evidence of mechanical obstruction. And finally, the gastroparesis, which is a functional gastric disorder caused by abnormal gastric motility with delayed stomach emptying in the absence of mechanical obstruction, as we see in this axial CT. The management is usually by endoscopic detorsion, which treat 80% of patients, and is recommended as the initial treatment in patients without ischemia or perforation. The second option is the emergency surgery, which include various non-definitive or definitive procedures. But resection with the primary anastomosis is the most commonly recommended because of high risk of recurrence if no definitive procedure was done. It's usually done in patient with peritonitis, bowel gangrene, or perforation, or if a non-operative treatment was unsuccessful. And finally, the percutaneous endoscopic colostomy, which is done in surgically unfit patient. The updated World Society of Emergency Surgery guideline have formalized the specific role of CT in dictating immediate clinical pathway. If a patient presented with suspected sigmoid volvulus, then contrast CT is done. If there was no complications, we should identify the anatomy and the subtypes. If it was organoaxial subtype, it usually have high success with endoscopic torsion in contrast to the mesenteroaxial, which have lower success, and close monitoring for early surgery must be done. If the patient have overt ischemia or perforation, emergency laparotomy or resection must be done. The emerging role of a dual energy CT or spectral CT first by iodine quantification or by the iodine map, which is the most critical feature in suspected volvulus or bowel obstruction. If a normal bowel will show iodine concentration of 2.5 milligram per mol, but the twisted sigmoid loop dropped 2.6 milligram per mol, so it is a definitive proof of microvascular ischemia. And second, by the virtual non-contrast image, which eliminate the need to scan the patient twice, so significantly reducing the radiation dose and immediately clarify whether the density is a pre-existing or represent a true active enhancement or bleeding. And finally, the low virtual monoenergetic image, which puts the contrast to noise ratio and makes septal vascular perforation defect in the mesenteric or bowel wall with much greater visibility. And this is a summary comparison between the conventional and the dual energy CT, where the dual uses 2 kV, while the conventional use single energy spectrum. Usually, the dual energy have objective assessment, while conventional CT have subjective assessment in bowel wall ischemia assessment. The dual energy CT suppress artifact and improve quality in contrast to conventional, which is more prone to beam hardening, which limit the quality. And finally, we can generate the VNC image from contrast phase, while the conventional CT require a separate scan, which will add an additional dose and time. This is an example of a 54-year-old woman with an acute superior mesenteric artery embolism and small bowel ischemia. This contrast enhanced coronal portal venous phase. Loop of ischemic bowel show decreased attenuation, as we see here, 28.1 Hounsfield unit relative to the perfused bowel, which show 77.1 Hounsfield unit on this image, which is a 40 keV reconstruction. This is the iodine uptake, also decreased in ischemic segment, 0.8 relative to the perfused segment, which show 1.8 milligram per mol in iodine map reconstruction. This CT show the iodine map reconstruction. And this is the 120 keV this is the 40 keV reconstruction, which show the increased relative attenuation difference between the perfused and ischemic bowel. The perfused bowel show 205 HU, and the ischemic bowel show the 46 HU. Take-home messages: the sigmoid volvulus is considered the commonest type of volvulus. The mortality rate is high. Bowel ischemia is considered the most serious complication and primarily affect individual over 50 years of age. This is my resources, and thank you.